So you're on the injury concepts part of my website here, and today's discussion is one of my favorites. Roughly 80% of the human population will at some point in their life deal with low back pain. And oftentimes that back pain is originating from the disc damage that occupies the space between your vertebrae, particularly here in your low back. As I've drawn a total picture of the spine here, and my head would sit up top here, and this would be my cervical spine. This would be my thoracic spine. Today's discussion, we're going to focus quite a bit here on the lumbar spine, and particularly the last two disc space. Most of the time throughout our lives, everything we've been doing that requires bending forward, it's like tying your shoes or picking things off the ground. We are very flexion-based animals. Flexion meaning I lean forward. We don't really do much in back bending. We do it all in flexion and forward. And what does flexion do to the lumbar spine? Well, in a perfect world, the lumbar spine is in a lordotic curve. So this curvature is called lordotic, where your neck is. This curvature is lordotic, where your low back is. And the mid-back is called kyphotic. But today's discussion, again, is we can focus on the lordotic spine in the low back, and in particular, the disc between L4 and L5, the most commonly injured disc. This disc happens to sit right in harm's way for almost all flexion events. So for you weight trainers out there that are doing deadlifts, you really have to pay attention to this. Any high school athlete that's being told to do squats and deadlifts or bent over rows should really listen to this. Anybody out there that's a plumber or a day laborer that has to bend over and pick up heavy items off the floor, really pay attention to this. This is information that's going to save you so much time and so much grief. I really want you to pay attention to this particular video. Probably one of the most, if not the most important video on all of my injury concepts videos. So we're giving credit today, as I do in each of these videos, to somebody that's taken a painstaking process of breaking this whole human body of ours down and trying to understand it and some of the most important elements of it. Dr. Stuart McGill, an amazing man. Highly recommended that you purchase any of his books or check out his videos on YouTube. I am replacing the video that I have on my current website with me discussing this today, only because Dr. McGill is being interviewed in the video. You get to meet the man, get to see what he's all about, and you get to see what a purist he is, as I am in my practice, to using science and rational ideas to break down the body into the injury processes that come to see us every day in our offices, and what do I do about this? So, you're suffering from low back pain. You've heard the term slip disc, protruded disc, sequestrated disc. There's all different words to describe damage that takes place to the disc. If we take a look at this disc, we've got an inner component of gel that is surrounded by a fibrous outer component, the annulus fibrosus. Every day, from the time you're a child, and as we age, flexion events or bending over put slight stresses on the fibers of that disc. And for most of us throughout the course of our lives, we're going to accumulate some damage, cracks and fissures, if you will, in this glycosaminoglycan, which is a sugar protein molecule matrix that forms the actual molecular basis for the disc material itself. But all hell breaks loose as you see this red dot here. That represents a nerve that's exiting your spine. That's oftentimes going to be the L4 or L5 nerve. In this case, it's actually the L5 nerve. The L4 nerve is exiting, but the L5 nerve exits below it, and it gets hit by a disc bulge at this level. So hence the symptomology oftentimes of sciatica, which is what happens when the disc injury is so severe that it hits a nerve. But low back pain isn't always sciatica. So I thought I'd clear that little misnomer up as well, as a lot of people come in to see me and they say, I have sciatica. Very few people actually have sciatica. Many people do have lumbar spine pain as a result of disc injury, but I want you guys to understand that I can just irritate that disc, meaning that on an MRI, it might look just like you see it here. This is actually a perfect disc. In a perfect world, the disc margin looks about what I've drawn there. But it's not a perfect world, and what happens over time is those fibers begin to crack and fissure, and then when you bend over, wrong, and we're going to talk about right today, and that's Dr. McGill's hip hinge concept, this jelly material here, this very hydrated, water-filled fluid is pushed slowly and inevitably begins to push outward, and then oftentimes later in our lives, at some point in our lives, causing the disc to protrude, push back, and start hitting the nerve, and hence sciatica. So we've got low back pain. That low back pain could be extremely severe and hurting you a lot, but it's still just an isolated disc irritation. So I've done something, maybe I've worked out wrong, maybe I picked up my child wrong. I know that I've treated a lot of moms that have that nasty stage between when your child is born and about 3 to 4 years of age, where you have to get your child into the car seat. A lot of young moms come to see me with this problem. It's a really pertinent problem, as you have to put that child into the middle of that minivan in the middle seat, because the law demands that we put the seat into the middle of the car, which means you're bending over and you're doing flexion, and then you're lifting this child that can be upwards of 20 or 30 or 40 pounds, and they're wriggling, they don't want to be put in the seat, and you got to put them down and strap them in. You're really going to love this video today, because we're going to talk about how Dr. McGill has analyzed not only the pathology of the disc, but how to avoid irritating it in the first place. So, again, the hip hinge concept works like this. I want you all to imagine that every time you bend over, you're going to maintain your lordosis. How do you do that? Well, when you bend over forward, if you can imagine, the curvature of my back looks like this, and I can actually hip hinge and bend over forward without ever changing the shape of that lumbar curvature. So you're going to use that very carefully to bend over by sticking your butt out. Looks a little weird, a little funny, but it's so worth it. So this is one of those functions where you might look foolish or might feel foolish, but if it means saving you months of back pain, and by the way, a lifetime of back pain, because this injury doesn't go away very well. The accumulation of the damage as a child is not completely repaired. It's interesting, some tendinitis, some ligament injuries, and some injuries themselves seem to repair fully, where we almost don't even know we ever had them. I've got a few of those in my own body. But some of the things I've injured, like my lumbar disc, mine being at L5-S1, have plagued me for years. And it wasn't until I finally discovered Dr. McGill's work on this subject during my schooling that I realized it was important for me to begin the prevention process, rather than what do I do every time my back disc injury flares back up again and I'm dealing with a week or two of chronic pain. So what you're going to need to do is a few different steps, and what I show patients, and there's actually a video that I'm going to be posting on my patient portal, is if you were in today and you had low back pain, I taught you these movements. What are these movements? Well, I love the door squat. A door squat is I'm going to stand in the doorway and I'm going to learn how to stick out my butt, tense my abdominal muscles, and breathe out before I put the load back into the back. So I'm going to stick out the butt, load into my quads and my abdominal muscles, lower myself down, keeping all the while the tension and the pressure on the musculature of my thighs and my abs, and not on the disc. And I can effectively bend over all day long without ever causing any cracks and fissures in the posterior parts, the back part of this disc. That's generally the one that is most problematic, because when the disc starts to become damaged from flexion, it always happens here. You will see X-rays and MRIs, or mostly MRIs of course, showing disc pathology going forward, but there's a big thick ligament in the way here, and the ligament doesn't allow the disc to protrude very well, and there's no nervous system in harm's way if a disc injury is moving forward or in the front. But when it moves back, all hell breaks loose, because the nervous system's involved. Now there's another big thick ligament here that is the posterior longitudinal ligament, And that is fairly effective at disallowing the disc to bulge straight back. But like you would see a stream divert around a rock, the water in the matrix of that disc is going to find that path of least resistance. And generally speaking, mine went left. Some of my patients have right-sided, some of my patients have left-sided, but very rarely are you going to have a central disc problem because you've got that posterior longitudinal ligament that's a very strong fibrous structure in the way, and it'll divert around it. So you're almost always going to see a left or a right paracentral disc protrusion. And if you read 1,000 MRIs like I have, you're going to see those terms used quite a bit. Many of you may have MRI reports. Go back to them, read them. I hope that this helps you to understand what that MRI is saying, and then descriptive words in it as mild, moderate, and severe can be used to determine whether the radiologist feels that this injury is mild, moderate, or severe. But you will know from pain whether it's mild, moderate, or severe. The great news about this, the disc does repair itself. In another video here on the injury concepts, you're going to see a beautiful picture that I found in the New England Journal of Medicine. 29-year-old female with one of the nastiest disc protrusions I've almost ever seen. And they did a 6-month follow-up study on her using I believe they used some glucocorticoid injections, so it could have been epidural injection or injection directly into the disc. But physical therapy was used, no surgical procedure. And you see the beautiful recession or regression of that disc back towards this. It wasn't perfect, but it doesn't have to be. The body does allow some level of breakdown before it becomes a chronic problem. So what's the takeaway of this? Dr. McGill's hip hinge is one of the most profound and meaningful things that you can learn and practice each day. Go into your doorway at home. Stick out your butt. Use your abdominal strength, use your quad strength, lower yourself down slowly, and learn the process of how to bend over properly using hip hinging. Again, from the side, butt out, bend over. I never compromise the shape of that back. It's always staying in neutral, even though I am lowering down. Practice this in the morning by putting your socks on. Attempt to try to keep that lumbar neutral position as you go and bringing your foot up to put your sock on. That's one of the more challenging things because the discs gel at night when they're injured, and and oftentimes many of you guys are experiencing that morning pain where you almost can't get out of bed. Roll to your side, get up sideways, be careful, move very cautiously. But this is all about learning, guys. It's learning how to move properly to prevent. That's the magic formula here. So, hope you enjoyed this video. Credit again goes to Dr. Stuart McGill. Remember, the more you know, the less you guess. Learn how to hip hinge. Apply it every day. You're going to prevent a lot of problems. Take